Hello, everybody. This lesson is about clinical decision-making in rare cancers. Let's assume that rare cancers are these ones. So these 12 major groups of rare cancers. Let's assume that therefore they are not so few. They are more than 20% of all new cancer cases, but they are different from each other. And so each of them, or each subgroup of them, is rare. So what is the problem for clinical decision-making? I would talk about both efficacy and effectiveness. Because there are problems with efficacy, there are problems with effectiveness. You may know that efficacy is the efficacy of treatment in ideal conditions. So in the conditions of clinical trials, the clinical trials are ideal settings in which an experiment is made. And this gives rise to the evidence of efficacy, which is published in scientific journals. But then when you want to implement evidence of efficacy in real conditions, in the real world, and this means translating efficacy into effectiveness. Okay, this depends on, first of all, the case mix, because clearly the case mix in real conditions is different, is always different from the case mix of clinical trials. The patients in clinical trials are somewhat selected. But depends also on the performance of the health system, the performance of the individual physician or professional, health professional. So in rare cancers, you have two groups of problems. The first one is that doing clinical studies is more difficult, and so generating evidence is more difficult. The second one is that the performance of medicine is clearly more difficult because it's not a given that the physician is experienced with the rare cancer he or she is dealing with, because rare cancers are rare. So we have a problem both with evidence and with performance. So as far as performance is concerned, what the clinician could do is to refer his or her patient to a center of expertise, specializing in that particular rare cancer which affects the patient. I mean, a very simple rule of clinical decision-making might be to refer rare cancer patients to centers of expertise. Today, this may mean also referring rare cancer patients to networks, because networks are more and more available, and a couple of lessons in this course are dedicated to networks. Through a network, the multidisciplinary tumor board, which you can find by definition in a reference center, can be created online. So if you don't have the pathologist, the surgeon experienced with that particular rare cancer, you may access to them within a healthcare network. So in theory, the patient should receive the same clinical decision and the same treatment which he or she would receive in a center of reference. There are several kinds of networks. There are professional networks which are created by professionals, by health professionals, with a bottom-up approach. And there are healthcare system networks, so networks created by healthcare systems with a top-down approach. But these are healthcare networks, in any case, by which distant physicians connect to each other. And basically, they exploit teleconsultations. But there is a big difference between an occasional teleconsultation and a teleconsultation within a network, because within an established network, physicians get used to working together. The same physician, even if distant from a center of expertise, will become used to that rare cancer, will specialize in that rare cancer. This is particularly true for medical oncologists. So a medical oncologist who cannot have the experienced pathologist, the experienced radiologist, the experienced surgeon at his or her institution can connect with them within a network. And at the end, he or she will specialize in that rare cancer, almost as a physician working at the center of reference. So this is the big difference between an occasional teleconsultation, which doesn't change quality of care. Of course, can benefit the occasional patient, sure, but doesn't improve quality of care in general, while a network works in a completely different way. So teleconsultations within a network are completely different from teleconsultations, which are made occasionally. Okay, this said, which is simple, I mean, referring patients or sharing patients with experts is simple, but which are the problems also for the experienced clinician? Which are the problems which are raised by the fact that the tumor is rare? Okay, there are many problems, and I will recall decision analysis, decision theory, because it's a method for clinical decision-making, clearly not just for rare cancers, but for all diseases, which is based on the on on very simple principles. First of all, the physician must imagine all the treatment options which are available. Then he or she must imagine what can happen following each of them, given the uncertainty which affects medicine, and we all know it very well. And in order to deal with uncertainty effectively, one must reason, conceptually speaking, in terms of probabilities. So probabilities will be what makes the difference, because if you are able to estimate probabilities of all what can happen following a treatment option, okay, then you will be able to manage uncertainty. Uncertainty will have been converted into risk. And then one must take into account patient's utilities, so the patient's preferences in conditions of risk. So this is the language of decision analysis, decision theory, in order to get to a rational decision in conditions of uncertainty, a decision which needs to be personalized, a decision which needs to be shared with the patient. Sharing uncertainty with your patient is what needs to be done when uncertainty is particularly important, as it can happen more frequently than with common diseases when you are dealing with a rare disease, including a rare cancer. And this means a shared patient-physician decision-making process, because clearly, first of all, this must follow a rigorous decision-making on the physician side. So the physician must have everything clear in mind about specific decision which needs to be made. And then at the end, okay, the uncertainty, the extra uncertainty which may be in place because the disease is rare, needs to be shared with the patient. But the patient must not be left alone. And so this is a reason why we talk of shared decisions with the patient, because the physician must be near to the patient and must allow the patient to deal even with the extra uncertainty and make the final decision as rationally as possible. But yes, it's possible that the rare cancer patient may experience some more uncertainty, so some more anxiety due to uncertainty than the patient with a common disease. This is price to pay, unfortunately. I mean, being able to manage probabilities is the key. And clearly this has to do with the quality of evidence, because which probabilities I will be able to share with the patient. Okay, this has to do with evidence-based medicine. and its pyramids of evidence. You know that evidence-based medicine makes this kind of ranking between studies which whose design may be felt as more appropriate, like randomized clinical trials, and then studies whose design is less satisfactory. So the quality of evidence may not be as high as the quality of evidence generated by the best clinical trials. By the way, it's not a given that being randomized makes a trial necessarily better than, for example, an uncontrolled study, because there are several other factors which determine the quality of evidence generated by a trial. But yes, clearly, in any case, I mean, we may have a different quality of evidence depending on the internal validity of a trial. For example, the study design affects the internal validity of a trial. So the internal validity in rare cancers may be not as satisfactory as in common cancers. If you are interested in some consensus recommendations generated by Rare Cancers Europe some years ago, you can find them in this paper, and you can find them in the recommendations from the EU Joint Action on Rare Cancers, in which you may particularly be interested in this assertion, which is quite strong, which says that in rare cancers, one should accept a higher degree of uncertainty in order to give a treatment, for example. So the concept is a higher degree of uncertainty should be accepted in rare cancers, because otherwise rare cancer patients would be discriminated against. Because it's clear, if I can do a large-scale randomized trial in a common cancer on a given technology, and let's say that that technology may be effective also in a rare cancer, and in the rare cancer you cannot make a trial generating the same quality of evidence, okay, then if you want the same quality of evidence as common cancers, the rare cancer patient would be discriminated against by definition. Look, this, speaking about probabilities, doesn't mean that the magnitude of benefit should be different. 1 year benefit in survival is the same in common and rare cancers. 1 week benefit in survival is the same, because the patient is a human being, and 1 week means the same for a human being, independent of whether he or she is affected by a rare or a common cancer. So the magnitude of benefit is not what one should assume may be different. The threshold in particular, in the magnitude of benefit, necessarily should be the same. But the uncertainty around this benefit in terms of a probability distribution may be wider, because you must accept more uncertainty. And it's not easy to share with your patient what is the risk, the magnitude of benefit, and what is the uncertainty around this magnitude of benefit. Clearly, in the information process, I mean, it's not easy to involve the patient into this kind of information, but an attempt should be made within a shared decision. Okay, what does this mean? I mean, just very trivially, if you take the type 1 and type 2 errors of clinical trials, for example, the alpha error, so the level of significance. Okay, this may mean that an acceptable p-value might be higher than 5%. In principle, because you accept a higher uncertainty. We are reasoning here under a frequentist logic, under which the p-value, you know, is the probability we had to find the difference we found if there were no difference, so under the null hypothesis, which is different from the Bayesian logic, which in principle is able to give you the probability that the treatment is effective, so something much more direct than the p-value. But this means using the Bayes theorem, which is very important, in particular, you know, in medical diagnosis. Because if you have the small image and you don't know if, for example, it is a metastasis or not, the answer may come from the Bayes theorem, which incorporates the sensitivity and the specificity, in this case of the CAT scan, but also must value the prior probability of disease, because you understand clearly that an image like that may have completely different meanings if the patient, say, is a patient who had a malignancy 1 year ago, or if he or she is a healthy patient without other diseases. So it's quite obvious that. And so the Bayes theorem is exactly what should lead you, rationally speaking, from textbooks to the clinic. In the textbooks, you find how often you may find a sign or a symptom in a disease. In the clinic, you need to know if a patient with that sign or symptom has the disease, which is clearly the opposite. And the Bayes theorem is able, conceptually speaking, of course, in terms of probabilities, to lead you from one side to the other. You know, if you must make the decision as to whether to take an umbrella, of course, you must take into consideration which is the month, the year, but you will take into consideration also the signs of the sky. And clearly the decision will be different in the two cases, but also be different depending on which month you are in. The problem is that this prior probability tends to be somewhat subjective. But on the other side, the added value is that, for example, in the prior probability, you could take into consideration the preclinical rationale. For example, if you have a new drug, a brand new drug with a very specific mechanism of action, okay, if in the disease you are talking about, this mechanism of action can be exploited. Okay, this I mean, gives a preclinical rationale to your decision, changes the prior probability. In Bayesian terms, you can factor in the prior probability. infrequentist terms, you cannot. It doesn't change. It doesn't. It's not different whether you have a preclinical rationale or not. You need a given number of patients in order to demonstrate what you want to demonstrate. The price to pay, however, in Bayesian terms, is that if the prior probability may be subjective, okay, then you should sell the results of a trial depending on whether you have an enthusiastic or a neutral or a skeptical prior probability. So there is a price to pay, but on the other side, you can talk explicitly about probabilities. They said probabilities are very important. They can also be viewed as degrees of belief. Because, you know, the other way of conceiving probabilities is in terms of objective frequencies. So one is objective, one is subjective, or maybe subjective. These are frequentist probabilities, while these are Bayesian probabilities, which can be subjective. My point here is just that also subjective probabilities have a full citizenship in probabilistic thinking. And the Bayes theorem is crucial in order to talk about probabilities in terms of degrees of belief. Okay, this said, I mean, this means that your clinical decision-making needs to be as rational as possible, as rigorous as possible. I mean, this clearly doesn't apply only to rare cancers or rare diseases, applies to any medical decision, but in particular when you have an excess of uncertainty, you need all the more to be rational in personalizing your decision and taking into account the uncertainty. Of course, in order to do that, you must factor in not only the results of clinical trials, but all the data which are available, all the real-world data which today artificial intelligence is able to process. Of course, there are risks, you know, this famous paper in which it was shown that in any trial, if you do too many analyses, you will find something statistically significant just because the number of analyses is too high. And this is true, this is a problem, but on the other side, when we are talking about rare cancers, we are talking about small populations, many subgroups, but also common cancers, you know, the other 80% of cancers today, especially for medical oncology, are split up into subgroups because this is precision oncology, which breaks down tumors into subgroups, into many subgroups. And so some of the problems of rare cancers may become also the problems of common cancers. And we should always recall that the results of a randomized clinical trial, but of any trial, have to do with the average trial patient. So we should be aware of how much homogeneous the trial patients are. So how much we can rely on the results for our patient, for our single patient. So to which extent our single patient overlaps the characteristics of the average patient of the trial. And here, the temptation in rare cancers may be to do large studies by putting together several subgroups, sometimes even several rare cancers. I mean, clearly you cannot do a trial in rare cancers because, otherwise you should do a trial also in, a single trial in patients with breast, lung, prostate, and colon cancer. So with the 4 most common cancers, clearly this wouldn't make any sense. And the same applies to rare cancers. So the external validity, we are talking now the external validity of a trial should be looked at, because clearly we must be sure that our patient corresponds to the average patient of the trial, and this average patient, doesn't correspond actually to too many different patients. So this has to do with clinical research, of course, but has also to do with the way you interpret clinical studies in order to make your decision, to translate the evidence from clinical trials into effectiveness into the single patient. On the other side, clearly you can also jump from one tumor to another, or at least from for example, from an age group to another. For example, there are some cancers which are typical of childhood, so they are rare, but then they also arise in adults, and they are all the more rare. Okay, clearly you may be able to do studies in childhood and not be able to do studies on these tumors in adulthood. But you can reasonably take the results of studies in children and use them in adults. Of course, reasoning, so applying your clinical reasoning, because, for example, an adult may not be able to tolerate the same dose intensity, for example, which may be acceptable in children. This may change the results a little bit. To which extent it depends on to which extent you have to make compromises. But in any case, this is clinical decision-making in rare cancers. This is perfectly legitimate. And I'm just implying that you have to reason all the more in rare cancers. Of course, you must reason in all patients, in all your patients, this is clear. For example, it's true that surrogate endpoints would be very useful in rare cancers, because generally a surrogate endpoint gives rise to differences which are higher than the differences in the natural endpoints like survival and quality of life. In particular, for example, you must have a big difference in response if you want to have a smaller difference in survival. So if you do a study on response rate, you need less patients. So, in clinical research, it would be easier to do a study in a rare cancer in comparison to doing it in a, it would be easier to use a surrogate endpoint in a rare cancer in comparison to doing the study on the natural endpoint on survival. But you need to validate surrogate endpoints, and clearly validation needs numbers, and numbers are exactly what you don't have so easy in rare cancers. But on the other side, never forget that, for example, this patient who has a sarcoma, a rare cancer, too close to the mesenteric vessels to be resectable, if achieves a response and becomes resectable, for sure this individual patient will improve his or her survival probabilities. So in this case, in this single case, survival will be improved by a response, aside from whether tumor response has been validated as a surrogate endpoint in this disease, or this patient who has a problem in the worst place possible. Of course, a response, and you can also estimate which degree of response would be needed in order to have a benefit, at least in quality of life. So you must reason between the clinical trial and the patient's bedside. There is a physician, and there is the shared decision-making between the physician and the patient, sharing the uncertainty, but also, trying to reason with the patient and to understand, for example, which is the attitude towards risk and towards uncertainty of your patient. Because this may change your decision. Whatever the results of the clinical trial, you should use the results of the clinical trial in order to make a personalized decision with your patient, and his or her attitude towards risk and uncertainty, we made this distinction before, may be important for the final decision. So this is the reason why I stressed the value of the methodology of clinical decision making. Again, I'm saying that this doesn't mean that you should be rigorous only in rare cancers. You should be rigorous whatever the diagnosis, but all the more, in rare cancers and rare diseases, you may be forced to be even more rigorous, because you have to come to terms with several constraints which are typical of rare cancers and rare diseases. But this, again, this has to do with medicine, with clinical medicine today, not only with rare cancers and rare diseases. Maybe doing clinical medicine in rare cancers and rare diseases may be very instructive also for our clinical practice, even when it doesn't affect rare cancers or rare diseases. These are my take-home messages. I hope this lesson may be useful. It may stimulate some of you also addressing these methodological issues, which are typical of rare cancers, but definitely not only. Thank you.